My name is Brenda Moynihan, and I'm the Director of Marketing and Outreach at the Kensington Assisted Living Residence. Tonight's presentation is Oh My Aching Head, update on the diagnosis, cause, and management of migraines and additional headache disorders. Before I introduce our speaker tonight, I'd like to briefly give you some information about the Kensington. The Kensington is an enhanced assisted living located in White Plains, New York. We are committed to providing outstanding care every day with the full spectrum of clinical support, including caring for those with Alzheimer's and additional dementias. We encourage independence and confidence and focus on making each individual feel important. Our promise is to love and care for your family as we do our own. We are bringing this presentation to you today because we recognize that headaches are a painful and sometimes disabling medical condition affecting millions of people, including caregivers. Our speaker today will be addressing the cause and approach to treating headaches and migraines. And folks, there's going to be a Q&A at the end of the presentation. And now our speaker, Peter McAllister, MD. Dr. McAllister is a board-certified physician in both neurology and headache medicine. He is the medical director of the New England Institute for Neurology and Headache in Stamford, Connecticut, and he's the chief medical officer of the New England Institute for Clinical Research, where he has been a principal investigator on over 200 clinical studies. Dr. McAllister holds clinical appointments at both Yale University and Quinnipiac University School of Medicine. He lectures extensively and has written over 100 articles, book chapters, abstracts, and posters. Dr. McAllister is recognized as a top doc in Connecticut and Metro New York by U.S. News and World Report. Welcome, Dr. McAllister.
Thank you very much, Brenda. Thank you for having me tonight. Welcome, everybody. Before I get started on migraine, I would say, as someone who also takes care of folks with Alzheimer's and other dementias, I know how important a facility like yours is, because that's what patients need when they need it. So I'm glad that you guys are there, and I like using you. So what we're going to talk about is mostly migraine, but we're going to do a smattering of other headaches as well. And as Brenda said, I run a tertiary care headache and neurology center just over the New York line in Stamford off the Merritt. And I run a research center there too, which we'll get to a bit, not only there, but at about 20 sites around the country. So we're going to talk about Headache 101. And trust me, by the time we get done with this about 30-minute presentation, you'll know more than your doctors do, which is good. So headache is very common. About 96% of the world has had a headache in his or her life, and about half of everyone has had a significant headache in the last year. That could be anything from migraine to hangover to tension headache to concussion. Migraine itself is the #1 medical condition headache that we treat, and it's just common as dirt. There's nearly 41 million people in the United States who have migraines, so it's 25% of all households, and 1 billion people around the world have migraine, making it the 3rd most prevalent illness according to the World Health Organization. The good news is nobody dies of migraine. The bad news is sometimes they wish they did. Migraine is quite disabling, and when I say that, I don't mean wheelchair type disabling. I mean lying in a dark room, nauseous, throwing up, light sensitive, unable to get out and go to work, missing a day of work, being docked pay, etc., missing a social event, a family event. So the World Health Organization also considers migraine to be the 2nd leading cause of years lived with a medical disability. Now, the other interesting thing is, although migraine is a chronic medical condition, it's often undertreated, often misdiagnosed, and many folks who have migraine aren't seeking the care of even general doctors, let alone general neurologists, let alone board-certified headache specialists. So we have a lot of work to do to close that gap. So there is, any organization has their international group, and there's a group called the International Headache Society, and they came up with a whole bunch of diagnoses. You don't need to know all the details here, but just the way we conceptualize headache is to divide it up into primary headache, in which the headache is the problem. There's nothing else going on. And secondary headache, meaning something is causing the headache. Something is down below, nefarious, bad in your brain or something causing headache. And I think that when people first start getting headaches, they always worry about the secondary headaches. I can't tell you how often I hear, is it a brain tumor? Is it a stroke? Is it an aneurysm, etc.? And while I treat those headaches all the time, the most common, really bad, awful, lay down, can't get out of bed headache by far is migraine. So the way we diagnose it is migraine lasts from about 4 hours to about 3 days. It's often one-sided, but not always. In fact, the word migraine comes from migraine or hemicrania or half a head. So the word migraine does mean half a head, although it can also be both sides. It's usually throbbing. It's usually moderate or severe. There's very rarely a mild migraine. If someone's got a very mild headache and they're calling it a migraine, it's probably not. It's probably a tension headache. Migraine is also worse by doing an activity, such as even running up the stairs. And it's got nausea or vomiting and light and sound sensitivity. That's how we diagnose migraine. 75% of migraine is just the bad pain with the nausea and the light and sound sensitivity. About 25% of the time, we have an aura. And an aura is a neurological thing that when you first have one seems a lot like a stroke. And the most common aura is visual, where patients will say, boy, it was so scary. I had zigzags or dots or a blind spot. It moved across my vision. Generally takes about a half hour. And then my headache came. So that's migraine with aura. Unlike migraine without aura, the migraine with aura is a real slight but significant risk for stroke. So we have to tell that to our migraine with aura patients. Now, the aura comes from a little electrical wave, like a tsunami. And if it's in the visual cortex, like it mostly is, it's a visual aura, as you see below there on the right. But it can also occur in the sensation part of the brain, and you get numbness or tingling. The motor part feels like a stroke. You can't move one side of the body. So migraine is really interesting. Unless it's you, then it can be quite scary. But it's just fascinating what can happen. I saw a teenager 2 days ago who lost part of his vision, and then he was scared. He wanted to text his mom, and he couldn't remember how to use his cell phone. I mean, he was 14 years old. So his brain just wasn't working. So when we teach the Yale fellows and residents, I tell them migraine is a brain disorder, not a pain disorder. Pain's common, but it is a brain disorder. Another one I won't touch too much upon, but it's called the suicide headache, and that's cluster headache. That's not very common. It's much more common in middle-aged men, where migraine is mostly young and middle-aged women. And think of a hot poker jammed into the eyeball. And it usually occurs in the wee hours of the morning, and it's awful. It's called the suicide headache because cluster headache has been called the worst pain on the planet, and patients sometimes commit suicide. So that's another one that a headache specialist would see. And there's a whole host. I won't dwell on this. You certainly don't have to memorize them. There's no test after, but there's some odd headaches. One of the more interesting ones, number 3, is sex headache, or what we call orgasmic cephalalgia. You can have a thunderclap, horrible headache at the point of orgasm. And boy, can that scare you. Most of those are benign, but some of them are related to small ruptures of aneurysms. There's another headache down below there. It says stabbing headache. We used to call that ice pick headache. Some folks have this variant in which they feel like they just got stabbed in the head for a second. They wince, It lasts 2, 3, 4 seconds and it goes away, and you could have clusters of those. And that's certainly treatable. Another fun one is hypnic headache. I've written on this. It's usually older women, and they wake up about the same time every night, let's say 2:17 a.m., with a headache. Interestingly, one of the main treatments of hypnic headache is a little bit of coffee before you go to bed. And you could say, well, how on earth can I get to sleep? They do. Hypnic headache responds to caffeine. The last one, new daily persistent headache, is an awful, chronic, lousy headache. And we call it new daily persistent because the patients can tell you the exact day it started. Let's say they lived 43 of their years headache-free, and they can say, Doc, it was August 13th, 2009. Headache started. That's new daily persistent. Now, there are some really bad secondary headaches. This is someone who's had a hemorrhage. That white stuff on the scan is a bleed in the brain. And usually those are different than migraine because they go from 0 to 60 in seconds or minutes. In other words, you go from no pain to within a minute or two, the worst pain you ever experienced in your life. And that could be a neurological emergency. And if that happens, you got to get to an ER. Now, the other thing that's become really much more diagnosed, we didn't even know about this 10 years ago, 12 years ago. You know how the blood pressure, we have normal blood pressure and we can have high and low blood pressure? Well, the spinal fluid, so the brain sits on top of the spinal cord and surrounded in a sac by water. The water is called spinal fluid. There is a normal spinal fluid pressure, so we can have headaches caused by high pressure of the CSF and low pressure of the CSF. And those are usually everyday headaches that don't respond to migraine meds. No one can figure them out. But if you get to a headache specialist who understands this, we can fix these often. You have to do a special scan, and you got to find out if there's been a leak of fluid causing low pressure, and then we can fix it. So what scares me when someone comes in with a headache? Well, older folks with a new headache, because that could be anything like a tumor, etc. If the story doesn't fit the typical migraine diagnosis, I saw someone who wound up having COVID with a severe atypical headache, and I knew it wasn't migraine. It turned out it was related to COVID. Someone whose headache comes on like that, 0 to 60, that can be one of those ruptured aneurysms I talked about. And of course, if someone has an abnormal exam, if they say, Doc, I've got 3 days of a headache and they can't lift their left arm, well, now we're thinking stroke and brain tumor, etc. So going back to the most common one of all of those, which is migraine, once we make that diagnosis, we have our patients keep a migraine or headache calendar. And that's really important because sometimes patients have no idea how many migraines they're having in a month until they see it displayed. And they're like, my gosh, I had no idea, even when I included the little ones, how many headache days I had. All right, so let's talk about treatment then. I didn't expect this slide with my name on it to show up again, but for those of you who joined late, I am Peter McAllister from New England Institute for Neurology and Headache in Stamford. So migraine treatment can be both really complex, but at its heart, migraine treatment is really simple. There's 3 buckets, and if you get these 3 buckets right, you're going to help the vast majority of your patients. The first bucket is lifestyle and behavioral changes a patient needs to make. The second is preventive treatment, something that you might take every day to decrease the number of headaches per month. And the third one is acute treatment to knock out that day's particular headache. Here's the problem. Lifestyle, behavioral, psychological issues, well, they're often ignored by doctors. Doctors too quickly tend to throw medicines at their patients without listening to them. Lifestyle and behavioral is extremely important, and I spend probably most of the visit with patients before we even get to anything near medicines talking about that, and I'll get into more of that in a second. Preventive treatment will take someone, let's say, with a daily pill or a monthly shot from, for example, 16 migraine days a month down to 2 or 3 or 4 migraine days a month. Now that sounds terrific, but it's way underutilized. Primary care doctors almost never give out preventive treatment, Even general neurologists don't often do it. So we need to close that gap. We need to treat more patients preventively. And acute treatment is often non-specific. It's not for migraine. So what do patients take, when they have a headache? Excedrin, Motrin, other things, sometimes narcotics, Percocet, Vicodin. None of those was designed to treat this medical condition, migraine. There are specific medical treatments for migraine, and they're underutilized. So we'll get to that too. All right. Migraine is, at its heart, the quintessential prototype biopsychosocial disorder. So what the heck does that mean? Biopsychosocial means migraine has a known biology. That's the first part. Migraine is as real as any other medical condition. Migraine's as real as Crohn's disease and asthma and diabetes, etc. And it has a genetics. It's inherited from the parents. Parent who has a migraine has a 50-50 chance of giving it to their child. Women, for a number of reasons, will express migraine more than men, even when boys get the gene. But it's also a psychosocial disorder in that if you have the genetics for migraine, if you're wired for it, life's internal and/or external stressors can make all the difference between having a handful of migraines a year or having 25 migraine days a month. So there are some things we can modify. So when I sit down with patients, I get all sorts of background history on them. I want to know their diet. I want to know if they drink enough water. Dehydration is a trigger. Do they skip meals? I want to know if they have anxiety or depression. Both of those conditions, anxiety and depression, run with migraine very strongly. They're genetically linked. So most of my migraine patients have at least anxiety and many have depression. I want to know how much stress is in their life. Sometimes I jokingly say, I can give all the meds I want, but someone needs a husbandectomy or a jobectomy. And until they address big issues like that, we're not going to be able to treat their migraines. How much are they exercising? Couch potatoes get a whole lot more migraine than folks who exercise regularly. That's been shown in teenagers and adults as well. And then PTSD. So we don't get to pick our parents and we don't get to pick our childhoods. And not everyone has had an idyllic growing up. And what it turns out from some very well done studies is if you have had childhood or young adult trauma, physical, sexual, emotional abuse, neglect, etc., you're much more likely to manifest migraine and you're much more likely to have very, very frequent or hard to treat migraines. So at our center, in addition to seeing the neurologist headache specialist, we have on hand psychologists, we do biofeedback, we have physical and occupational therapists, we have nutritionists, we have massage. Sometimes those deep muscles in the back of the head, neck, and shoulders are causing or worsening migraines. Sometimes grinding your teeth can be a trigger for migraines. We use sleep studies. We teach meditation and yoga and mindfulness. And I will tell you, some of this may sound new agey, but I'm a research scientist. So I know that each of these has either good or excellent data in studies. All right. So prevention therapy, that's usually, until these more modern times, a daily pill you take. Some of you may have heard of Topamax or topiramate or amitriptyline or a beta blocker such as propranolol. If you take those and you're lucky, you can decrease the number of migraines per month, the severity of migraines, and decrease your disability. I mean, that's really good. And if you happen to have no side effects on it, that's even better. So we have to make sure the person actually has migraine before we give them a preventive drug. We have to know what's going on with them. What other meds are they on? I don't want to give them a med that's going to make their other med not work. Are they planning on having a child soon? Some of these daily pills are quite harmful to a pregnant person or the fetus. I want to know, everything. I want to know if they're overweight. One of the migraine preventives, number one side effect is weight loss. And when I get someone to drop their monthly migraine days by, say, 70%, and they've lost 14 pounds to boot, I tend to get nice holiday presents from those people. Migraine preventive therapy takes a while. So you've got to give it months. I've had patients, I start on a medicine and they email me, because my patients get my email. They email me 4 days later and said, you know, my headaches aren't gone now. How come? And that means I didn't do my job. Telling them that it can take 4 to 6 weeks, sometimes even 2 months. Sometimes the meds don't work or they have side effects, so we'd have to have an exit strategy. And sometimes we have to listen to our patients, but we also have to be firm and kind of be a cheerleader to support them through it, particularly if they have a little side effect. Some patients want to just bail out of their medicines, and I say, you know what, why don't you stick it out a few more days and get back to me? And often that's enough to, you know, get their side effects down to a lower level or gone. So we can divide migraine preventive therapy into the old guys, which are pills and Botox. All of the old ones were discovered accidentally. So high blood pressure pill that happened to decrease headaches. We did a study, it works for migraine. Everyone knows the Botox story, right? So women were going, mostly women, to their cosmetic docs and getting Botox for wrinkles. And then some of them were coming back and saying, hey, it's great, I look 10 years younger, but by the way, I used to have these throw up, you know, horrible migraines, and I don't have them anymore. And that led to about a decade worth of research. And I was a principal investigator on the study that got it approved. It's now approved for chronic migraine, for people who have 15 or more headache days a month. If you look to the right side of the slide, April of 2018 changed everything, because this is when we got the first of the monthly shots that you may have seen advertised in magazines and on TV. Aimovig, Ajovy, Emgality, etc. So for the first time ever, these drugs were designed specifically for the disease migraine, based on what we know chemically about the screw-up that happens that causes migraine pain. So that was really pretty exciting stuff. Then there's also vitamins and supplements. Again, because I'm scientific, there's a lot of craziness out there, and you will hear a lot of nonsense, and you should be very critical and not believe everything you're told. However, there are some vitamins and supplements that have gone through study. Riboflavin, which is vitamin B2, is actually quite effective. Magnesium in some people is effective. Coenzyme Q10, feverfew, those can be effective. Then there's a supplement, it's the bark of a little tree called Petadolex, or butterbur is the other name for it. And that's been shown to be very effective. But just because something is natural or, you know, a supplement doesn't mean it's not dangerous. There have been a few cases of liver abnormalities with this butterbur Petadolex. So we're not using it as much as we used to, but it is very effective. I mentioned pregnancy. So there are some meds that are much safer to use, and some that are, you know, you've got to really weigh the risks and benefits, and some you would never use because they cause birth defects. Breastfeeding is a little easier. I have, so who gets migraines? People who often get pregnant. So I've had many patients of mine over 25 years get pregnant, and, you know, we just have to work them through it. Most pregnant people have a decrease or even elimination of their headaches, particularly the second and third trimester, and for the first 3 months after the baby pops out. In fact, some of my migraine sufferers wish they could be pregnant all their lives, because it's the only time that they didn't have disabling migraines. So now we're in the era of these shots, monthly or quarterly, and they're called CGRP monoclonal antibodies. A monoclonal antibody, think engineered smart molecule. So when you inject this thing into your thigh or into a little belly fat once a month, it takes about 5 or 6 seconds. They're designed, they've got like little warheads, and they're designed just to go right to the migraine center where the trouble is, turn off the migraine causing bad guy, hang out there for about a month, and then get broken down and discarded. The beauty is they don't go to your liver, they don't go to your kidney, they don't go to your heart. They don't interact with any other medicines you're on. You can be on some big meds and you can do this and not have to worry about it. It's also nice that, you know, let's say it takes 6 seconds for the shot to get in, 6 seconds a month. So that's what, about 72 seconds a year you're treating your migraine. and every other waking second, minute, hour, you're not. And that's really nice. So this is the first time we've had that. And don't worry about all the details here. Up top, you see the brands, Aimovig, Jovium, Gality. There is an intravenous or IV formulation. So if you did okay on one of those other ones, but you want to see if you can do better, this one's stronger. And that's every 3 months. We do that in the office. So what about the knocker outers? That's my last class of treatment. Something that when you have a migraine, what do you go to? Well, one important concept is this. When you feel a headache coming on that's a migraine, treat it early. Turns out many of our patients, and even doctors who get migraines themselves, wait too long. They kind of wish it wasn't there. They take a shower. They take Tylenol. They kind of hope to will it away, perhaps. But it's a migraine. And the quicker you get to it and put out that fire, the more successful it is. Here's another weird thing. If you take almost any migraine medicine very frequently, it actually can cause headaches. We call that rebound or medication overuse. So the worst offender is one called Excedrin or Excedrin migraine. And then there's a prescription similar drug called Fioricet or Fiorinol. Those, if you take them more than 6 days a month, can cause everyday headache. So it's important to try to limit your migraine meds, acute meds, to twice a week, occasionally 3 times. We also know that in the face of migraine, the gut, the stomach, tends to stop working as well. And that's why people often feel nauseous. So it's hard to absorb things when you take them as a pill. So we have nasal sprays, we have shots, we have other ways to get the migraine med in, and those tend to be a little more effective and faster than the pills, although I still use pills too because it is the preferred form. So again, many patients are taking over-the-counter Motrin or Relieve, and I'm not saying don't. I'm just saying that if you take too much of that, it's not good for your stomach or your kidneys or liver, and it can cause rebound headache. It's not all that effective for the bad migraines. And don't take narcotics for migraine. They don't usually work. The specific ones are triptans like sumatriptan and Imitrex. The new classes, the Ditan is called Rayvow. The Gepants are Ubrelvy and Nurtec. There's a Cambia is a powder you dissolve in water and you drink like a shot. I love that drug. And then there's neurostimulators, which I'll say a little bit about because they're pretty cool actually. So neuromodulation is when you do electrical or electrochemical or energy signals into the brain to stop a migraine. So the way I describe it is when we use a medicine, we're using chemistry to fix your migraine. With a neurostimulator or modulator, you're using physics to treat your migraine. I won't go into all these. Just look at the left, the very top one and the bottom one. Cephaly is a little stimulator of some nerves on the head, and you actually stick it on your forehead and push a button, and it does a 20-minute cycle every day. The interesting thing about that is it just became over-the-counter today. So you don't need a prescription. You can just buy it yourself because it's virtually harmless. Go all the way down to the bottom one. The newest one is called Neurivio, and this is kind of neat, and the data is good. I was an investigator on this little guy. If you put this thing, when you have a migraine, you put this armband on your arm. It's got a little battery. That battery is Bluetooth enabled to an app on your cell phone. And what you do is when you get a migraine, you put this on, you dial up on your phone a little bit of juice, and you actually feel a stimulation on your arm. And that stimulation, it's not painful, travels up the arm to the brain, and as the migraine signals are going down, the energy from the armband is going up, and it goes, and it works as well as our best oral treatment, knocker-outers. The cool thing is it has no side effects, of course, because it's not going to your liver. You don't swallow this thing, it just goes on your arm. So it's pretty cool, and it costs, depending on the deal they have, between $2 and $8 per migraine attack. So there's that. All right, so in summary, and then I'll be happy to take questions, migraine is a medical condition. It's a chronic medical condition with attacks, and those attacks can be 4 times a year, 10 times a month, 30 times a month. It can be disabling, meaning you miss stuff. You miss work, you miss social events, you miss family events. There are lots of ways to treat this, but you have to go to someone who knows what he or she is talking about. I'll put a plug in quickly because the only way we got all of these cool new meds I told you about is through clinical studies. At our site, we did all of the Ajovis, Aimovigs, all of the new pills that have just come out, the armband. And what do patients get? They get free medicine, free doctor visits, free tests. You actually get paid a wee bit of money. I think it's $75 per time you come in, because the FDA says any legit research should not cost a patient a dime out of pocket. And patients usually enjoy it. We've got several migraine studies going on now, including a really cool nasal spray. And if you want to contact me, you see below there, we'd be happy to get you in. The important thing is to recognize the biopsychosocial nature of migraine. The things that you can impact, your sleep, your diet, your hydration status. Too much alcohol is bad. Too much caffeine is bad. The most important one of all, stress. So if you're going to take care of only one biopsychosocial thing, forget about the diet, forget about the hydration, work on your stress. That's the number one trigger. There are things you can't help. Barometric pressure causes migraine. You could, I guess, move to Arizona, but when bad weather comes in, you can't help a menstrual period. Or can you? Sometimes we put people on low-dose continuous birth control, and it takes care of their menstrual migraines. You can't help if you've had a concussion. A concussion is a trigger or risk factor for having migraines later on. So I say, fix the things you can fix, and adapt to the things that you can't and realize that they're there. And work with the doctor. I always make it a two-way street. It's shared decision-making. And you want to have a good relationship with your practitioner because you want to be able to access him or her. You want to be able to get acute treatment. Let's say your home treatment fails every now and then. We have a drop-in headache center where you can just show up. We put an IV in you in a dark, quiet room and knock out your headache. So that's it. Below there, you see our website. Our Instagram is fun and entertaining and informative. It's Headache Docs. So if you want to follow us, feel free to. So with that, I'm going to stop. And I think, Brenda, if any questions came in, why don't you let me know and I'll try to answer them. Brenda, you may still be muted. Oh, I think I hear
you. Can you hear me?
Yep.
Okay, great. Thank you, Dr. McAllister. So we have a couple of people who have written their questions prior to the presentation. And the first is, I have suffered with migraines for over 40 years and have taken a myriad of pills with only some relief. 2 years ago, I was prescribed Ajovi, 1 time a month injection. This has been my miracle treatment. I no longer have daily pain, although I still take Imitrex as needed for breakthrough pain. I can live every day pain-free. My problem is I'm now retiring and signing up for Medicare. There's no coverage on any plan for Ajovi. I will have to pay approximately $800 to $1,000 out of pocket for the Ajovi every month. Please help with any suggestions.
Okay, well, I'm glad you're doing much better on those drugs. I've heard plenty of stories like that too. These new monthly shots are really pretty impressive. But they're not, whoops, I think I just, hang on, I'll get back in here.
I think it's the video.
Let's see. Sorry. Whoop. Okay, so yes, they're impressive. B, monoclonal antibodies are extraordinarily expensive to manufacture. Most monoclonal antibodies for things like arthritis, multiple sclerosis, etc., cost many tens of thousands of dollars a year. These cost about $600 a month, which is still not cheap, I grant you. What I can tell you is the following. Some Medicare plans do cover it. I've gotten people on Medicare coverage, so make sure you really look into it. Sometimes they say no, but you have to, kick them in the ankles, and I advocate for my patients, and we get it covered. The second thing is you can get a supplemental, and you can check out the supplemental to see if they cover. So your Medicare plan has to deny it, and then the supplemental can pick it up sometimes. And then lastly, if you go to a headache center, we get samples of these drugs, and we don't mind sharing them. So what if, again, if everything else failed, and maybe every other month we gave you a freebie, well, we've just dropped your charges by 50%. It's not a perfect solution, but it makes it at least somewhat more livable. So all of those options are there, but make sure that your doctor is advocating for you to your health insurance company.
Okay, thank you. I have someone who's just written, I've used Ajovy on September 15th, and the following day I was sicker for the longest amount of time than ever before. Wondering if you've ever heard of this before. It actually caused a migraine with unrelenting vomiting for about 2 weeks.
Yes, the world is unpredictable. We know that, given our politics and our pandemic. When we say that these medicines have virtually no side effects, we mean that they have virtually no side effects in almost everybody. But I've seen weird things. I've seen constipation. Someone was convinced it thinned their hair a little bit. It's not reported, but it's out there. I've had patients who, reacted to the shot. I've had patients who had anxiety reactions after it too. So it's interesting as a clinical researcher. Sometimes in a study, someone does say an injection and then has a horrible reaction, so bad that we break the blind and find out what they got, and they got placebo. They got the fake one. So the brain is very complicated. All I can tell you, although you probably wouldn't take me up on this, if you did it again next month, you probably wouldn't have that. Or if you switch to one of the other shots, you probably wouldn't have it. I see that all the time. So I'm sorry that happened to you. Most of the time, in most people, these are among the best tolerated migraine, preventives we have.
Okay, thank you. I have someone who's written, I'm experiencing migraines daily and am postmenopausal. Could it be due to hormonal problems?
Not if you're fully postmenopausal. That means estrogen has gone all the way down over usually months or several years in the perimenopausal state to 0. Most women who are 2 years or more postmenopausal do get a break in their migraines. They're either a little better, a lot better, or they're gone. Certainly, hormones are a major trigger in the non-postmenopausal person. So often, girls and boys have the same amount of migraines. Then girls get their period and they take off. Adult women around their period, 40% have a menstrual migraine. And then at the time in the late 40s, early 50s, when you start skipping periods, spotting, hot flashes, etc., migraines go through the roof again because the hormones are all over the map. Once they sink to 0, it no longer becomes a hormone issue. So either your brain is now wired from many, many, many years of migraine, or there's something else going on that maybe we can impact.
Okay. It says here, you mentioned clinical research for migraines. What studies are available?
So we always have a number of studies, and I should take a step back for a second, and we do studies across neurology. We have 4 Alzheimer's studies. We have 2 Parkinson's studies. We have stroke, spasticity, cluster headache, all sorts of interesting stuff, all free. Some of the Alzheimer's studies are extremely fancy, involving PET scans and state-of-the-art stuff. As far as migraines, we have 3 acute medicines, pills and sprays. We also have the shots that have already been approved. We're looking at them, for example, Aimovig, the first one out. We're looking at a study on how people's work productivity enhances. What's in it for you? Free med, free doctor visit for a long time, and you get paid. We have one on Ajovy because when we did that study, we looked at depression, and we were surprised as anything to find that some folks' depression got better on Ajovy. So now, if you happen to have migraine and depression, which is pretty common, we have a study for that, looking to see if we can solve that question. We're also looking at a real-world study on the IV migraine med I mentioned, called Vyepti, where again, you'd get quarterly free IV medicine, and we want to see how it does in the real world, how you function, how you work, what your life is like, your sleep, etc. All of this is really important data. And then lastly, kids can get disabling migraines too. We have a number of really interesting pediatric and adolescent migraine studies.
Wow, interesting. Thank you. I have someone who just asked about the armband, the physics, the armband. You had mentioned that there was something else that's now over the counter. What about the armband?
The armband is not. You need to see a doctor and get a prescription for it. However, I don't have a crystal ball, but I suspect that'll be over the counter in a few years. I mean, it has no side effects, so it probably will be over the counter. But right now, you need to get it from a doctor, a prescription.
Okay. This person writes, I've had migraines for a number of years, but was just recently diagnosed. I take triptan when possible and it helps me, but I tend to be one of those people who, as you mentioned, tends to deny or be unsure that a migraine is actually happening before it's too late. Do you have any recommendations for identifying the onset of a migraine, especially as opposed to something else like jet lag, sleep deprivation, etc.?
So yeah, that can be hard. Migraine sufferers tend to get more regular headaches than the rest of us anyway. They get more jet lag headaches. They get more ice cream headaches. They just get more regular headaches. They're wired for headaches. So how do you know it's a migraine? Well, if your headaches are infrequent, let's say 3 a year. Sorry if I stopped the screen. I'm having little issues here. Can you still hear? Oh.
I can see you, but not your presentation anymore.
All right. Well, it wasn't anything to see. Sorry that went out. If it's infrequent, I would say really try every headache taking a triptan and just jotting down what happens. Triptans are statistically safer than Tylenol. That might surprise you, but it's true. So if you have 3 or 4 or 5 headaches and you're not sure they're migraine, take the darn triptan anyway, even if it's jet lag or whatever, because it isn't going to hurt. And then you'll get a sense of what's what. If you have very frequent headaches, some migraines, some not, that becomes harder, and you're the candidate to be on a preventive medicine.
Okay. Can you talk about the pros and cons of the new injectable meds like Aimovig and oral Ubrelvy?
So one con is the little needle stings for about 6 or 8 seconds. You know, it's a very tiny needle, but it's got a little bit of a sting. The other thing that you could say, if you're very conservative, is that they've only been out for a few years. So who knows, are we going to get cancer or grow a third arm in 10 years when we get lots of people on it? We've got, many years of animal data. We now have 5 full years of human data with nearly 1 million people around the globe on them. So I'm convinced they're pretty safe. So that's all, things that you could be legitimately concerned about. We do not know how they work in pregnant people. Now, we may find 5 years from now they're perfectly safe for a pregnant person, go for it. But right now, I do not recommend them if you are pregnant or if you are thinking about becoming pregnant. In the studies, life happens in research. And there were pregnancies in all of the studies, because I was involved in all of them. And I wasn't involved in the pregnancies. I was involved in the studies. And nobody had a bad outcome. But there's such a small sample size, we're going to need years to know whether it's safe. So if you're looking to start a family, don't take those monthly shots.
Okay. For someone who tried one of the injectables, but it eventually stopped working, would another possibly be better?
Yes. It's amazing. You know how some taste buds, it's got to be Starbucks coffee, and some are just, it's got to be Dunkin' Donuts, and they can tell the difference, and they won't drink the other one. But at the end of the day, it's a coffee bean, right? Well, it's the same thing. These drugs are similar but different, and some brains are going to respond to one more than the other. And I can't tell you how many times I've switched from Aimovig to Ajovy or Ajovy to Emgality, and they're like, man, why didn't you start me on this one before? And I was like, how would I know? But yes, it's absolutely worth trying at least 2 of them. And if you don't respond to 2, you're probably not going to respond.
Okay. Can an allergy to makeup cause headaches?
Not that I know of. Allergies themselves can be trigger for headache. So if you're getting inflamed around the eyes, inflamed around the face, I could see theoretically, but there's no scientific studies on that.
Okay. Strategies that work for people who have chronic frequent migraines despite the use of preventative medications. What alternative health methods have been shown to help?
Well, I don't want to sound like a cynic, but none have been shown. That doesn't mean they don't work. So we use therapeutic massage. I have used acupuncture with some success and with some failures. I have done a lot of biofeedback and psychosocial work. Biofeedback can be sometimes effective when nothing else works. And then sometimes acceptance. If you are a catastrophizer, if you're wired such that every pain to you is just awful and you think you're going to die or something, getting your head around the idea that it's not going to kill you, it's going to be okay, you can partially control it and get to a lower pain state, sometimes when all else fails, that's somewhat helpful for quality of life.
Okay, thank you. Does anyone have any more questions? Please type in the chat box on the bottom of your screen. No? Okay. I'd like to thank you all for joining us, and especially Dr. McAllister. I'd also like to thank my colleague, Christiane Lee, for assistance in providing this virtual presentation to you today. If you would like to get in touch with Dr. McAllister, please feel free to go to his website at www.neinh.com or call 203-914-1900. Again, 203-914-1900. And if you'd like to get in touch with the Kensington, please feel free to call us at 914-390-0080 or go to our website at www.thekensingtonwhiteplains.com. Thank you again, Dr. McAllister. Thank you all for joining us this evening, and have a great night.
Thank you. Good night.